here, so everyone else ready to get started?
Yep.
Awesome.
This is Tracy.
So welcome everybody to the November Practice Facilitator Network webinar. I don't know about anyone else, but I totally forgot that there was a time change today, so it was nice waking up with an extra hour to do stuff. So I guess we could start by just shifting over to the next slide. And we'll start off with a little bit of a poll. If you remember from the past webinars, go into your browser on your phone or your computer and enter the website up at the top of the screen there, and you can text your answer to this question. What did you or your kids dress up for Halloween this year? I'm noticing a lot of animals. I went with the easiest name possible, and I just went as Inside Out and turned all my clothes inside out, so pretty easy costume. We could probably move on to the next slide. Get things going. This is a slide we'll probably be presenting on every webinar we do now, just stating the vision and mission statement of the Practice Facilitator Network that we came up with not too long ago. So just to reiterate, our vision is every practice facilitator is supported to facilitate implementation of the patient's medical home, and our mission to build a culture of continuous quality improvement. And then we have some new information to share with everybody. So if we could go to the next slide. We did a poll in the past, and we asked everyone on the call to vote for what values they hold the highest as a practice facilitator. So here's a list of the top results, including evidence-based, collaboration, connections, safe patient care, and joy in work. Which, as a little FYI, joy in work was actually lower down on the rankings. Kind of appeared at the bottom of the poll list, which was interesting because if you think about it, we should be taking joy in the work that we do towards improvement and kind of helping with the medical home. So it got bumped onto the list because it's something that's easily forgotten or falls to the wayside. Just, you get busy, everything's happening all at once. So hopefully by adding it to the list, it will be a little reminder to everybody working in the improvement work that how important it is to have joy in the work that you do, because we're all kind of making an impact, and it's definitely positive. And another note, continuous improvement was actually one of the top voted responses. I think it was the top voted response in the poll. And because our Practice Facilitator Network mission statement kind of builds upon reinforcing a culture of continuous improvement already, it's kind of redundant to repeat that in the values. So that got bumped out, and joy in work was replaced by it. I think it fits a little better. I definitely like the reminder, because every often you got to stop and remind yourself, just slow down or enjoy it. So this is the new values that we came up with based off polling everyone. I think they're pretty great. Move on to the next slide. Just a reminder, a little bit of technology update. if you cannot see the chat window on the right-hand side of your WebEx screen, just click on the little bubble with the chat window, and it'll populate the little chat window on the bottom. If you're having any issues, make sure you change the address to the host, which is Leanne, and she'll help you out with any technical difficulties you might be having. Maybe you can't hear or see the chat. As well, if you want to load participants, you can click that next to it. So we can move on to the next slide. Using the chat function, if anyone could just type your name and organization, who's on the call. If you're in a room with a bunch of people, make sure you include how many people you're with, just so we can get a head count to do our own quality improvement or see how many people are on the line. Oh, I can't read that fast. There's a lot coming in. See some people from the North Zone. That's where I am. South Calgary, Chinook, Cold Lake. I saw Edmonton earlier. Say hello to everybody. I think we could, that's enough time. I think we could probably jump to the next slide. For some of you that might remember, the Practice Facilitator Self-Assessment went out not too long ago. So I have Wanda from the AMA. She just wants to do a little blurb of what it's about, and I'll pass the buck over to you, Wanda.
Okay. Thanks, Matt. Thank you so much for having me. So I just wanted to remind everyone that the online Practice Facilitator Self-Assessment is live, and it's available until November 15th. We did have some technical challenges with the report, so it didn't get sent out right away the last time we talked about this on the webinar, but it's up and running now, and some of you have already completed it, so that's great. It takes about 20 to 30 minutes to complete, and you get a snazzy personalized report with your results, and you can choose to download this as a PDF. And I also wanted to let you know that the survey does collect personally identifiable information by asking for your name and email address. And this is just to ensure that we can track changes over time. But because of this, we have taken measures to mitigate any risks with collecting your information, which will only be viewed by me, the evaluator on this project. And so I will ensure that the data remains anonymous in the aggregation and reporting. So for example, if a PCN has fewer than 5 people completing the self-assessment, then we will not report back that data at the PCN level. So just wanted to let you know that this is available and will be available until November 15th. And if you have any questions, don't hesitate to reach out to me. And you can also email pfadmin@albertadoctors.org if you have any questions.
Awesome. Thank you very much, Wanda. I did the assessment, and I was pretty impressed with the little output that it gives you with all of your stats and stuff. I thought it was really cool visualizations. So moving on, I'll introduce Emily from the AMA. She's going to go over some change packages and layering. So you can take it away, Emily.
Great. Thanks, Matt. So hi, everyone. My name's Emily, and I work for the Alberta Medical Association. I'm with the Accelerating Change Transformation Team, or the ACT team. I'm here today to talk to you about using and layering of change packages. So we know as practice facilitators that supporting teams to operate as patients' medical homes requires the layering of many elements over time. These elements might include things like helping a team to identify and maintain their panel, having good continuity, coordinating and distributing the workload amongst teams, optimizing your EMR, providing patient-centered care, timely access, the list goes on and on. So today we're going to be talking about the tools that help practice facilitators to do that, and the tools we're specifically talking about today are the change packages. Last time I was here, which was in September, we talked about this new practice facilitator competency document. And just to remind you that one of the competencies that is required of practice facilitators to support the transformation is to be able to propose specific change packages to achieve practice goals, to advance the patient's medical home, and to be able to layer these change activities between the various change packages. So I'm hoping after today hearing from me and then hearing from some actual stories in the field, you'll feel a little more confident to do this. We can go to the next slide, Leanne. So let's just start with talking about first what the heck is a change package. It's kind of a jargony word, but a change package actually makes a clinic improvement team's work easier. Kind of like a roadmap that guides you along routes that other people have found and other teams have found successful. It isn't meant to be prescriptive, but rather to provide information from places like literature, if there's been research done, clinical practice guidelines, expert recommendations, and these can be considered and adapted within the unique context of the clinic that you're supporting. We can go to the next slide. So what are the components of a change package? So there's lots of change packages available. ACT produces some. There's some that you might find from other organizations around the world, but how ACT organizes them is that we have 4 main categories, and they're called high impact changes, potentially better practices, or PBPs for short, process measures, and some key tools and resources. So I'm going to define each of these because it's likely going to be new terms to some people. So a high impact change represents the main areas of focus that are considered to be most critical for a clinic to work on to achieve optimal performance in a particular area. And so a common high impact change that you'll see is something like improving the patient's experience. Because if you're able to do that, you'll likely have a high impact on whichever clinical area it is that you're working on. The second one is the potentially better practices, or the PBPs. And these are specific processes and practices that can be tested in each clinic and implemented based on your own clinic's context. So PBPs are typically derived from literature, clinical practice guidelines, or expert recommendations. But the reason we call them, in air quotes, potentially better practices and not just better or best practices is because not all PBPs are based on a clinical practice guideline where we know for sure this is the way forward. Sometimes they come from other people's practices who've tried something new and had success. Therefore, we say potentially so that teams know that each PBP will need to be considered within the context that they work. Next, we have process measures. So when changes are tested without measuring, it's really difficult to know for certain if a true process improvement is occurring. The suggested measure in a change package, these are typically simple things to implement and track. And it is important to note that measurement for improvement is far less rigorous than measurement for research. And we're gathering just enough data to know if a process is working. So that's the goal around measurement. And lastly, we often link some key tools and resources, and this one's a pretty self-explanatory category. The change package tools offer teams a place to start when they're testing their PBPs. The tools represent a set of sort of tried and true options, but they're not a requirement. For example, one change package tool might be an EMR guide that would help you to do the steps in the EMR that would enable a potentially better practice change. So we can go to the next slide, Leanne. Now that we know what change packages are, let's talk about who they're for. So change packages were originally, at least the ones from the ACT team, sort of seen as a behind-the-scenes document. But now that practice facilitators in Alberta are being challenged to support practice teams with multiple interventions, we know that you need to take the tools into your own hands. Therefore, the primary audience for these change packages are those who are supporting transformational work in the province, so specifically you guys as practice facilitators and physician champions. They're designed to be used at the clinic level and hopefully to achieve improvement in a specific clinical area in your PCN, in your clinic, in your PCN, and in your zone. We can go to the next slide. So I did want to mention that it is important to remember that change packages should be considered by teams as a menu of options and not a recipe that you have to precisely follow. So I think of change packages being akin to a menu because they have a variety of change ideas from which you can choose and test something. So you might pick one or two things to PDSA or to try out initially, but you shouldn't certainly feel like you have to do everything on the menu in a specific order, and definitely not all at once, or that would be really overwhelming for a team. We can go to the next slide. So let's look at the change packages that currently exist in Alberta. These were specifically built because they are priority areas of focus within the province. So right now, the ACT team has 5 change packages that are available to practice facilitators to have at their disposal. All of these change packages support the implementation of one or more of the patient's medical home implementation elements. You can see the arrows going to one of the implementation elements on the house, and we know that things like continuity support multiple of these implementation steps, but we just picked one to highlight for simplicity. So if we go from the bottom to the top, starting at the panel processes, you can see that it supports the panel and continuity implementation element. The relational continuity change package also supports that same element, and it is interesting to note that both the panel and the relational continuity change packages are considered to be sort of the foundational work, and it's kind of difficult to move on to some of the more higher order change packages without establishing first who's on your panel and that there's an ongoing therapeutic relationship. But sometimes that's not what we call a clinical hook. Maybe it's opioids that gets a physician or a team interested in doing this work. And so practice facilitators can have both of those change packages at their disposal to see where they might have to go back to do some foundational work before moving on to some of the more opioid-specific processes. Then we have the screening and prevention change package, previously known to some as ASAP, which supports organized and evidence-based care. The opioid processes change package, which also supports organized evidence-based care. And our most recent change package is the Care Planning 1, or for those who are involved in the pilot, you might know it as PACT, or Patients Collaborating with Teams. And this supports the patient-centered interactions implementation element. So we can go to the next slide. So I included in here a couple examples of what the change packages look like because they're pretty hot off the press. In fact, I just got this new design look even just this morning. So this is an example of one of the change packages we have, which happens to be the panel processes change package. And to help teams focus, all the new change packages that will be coming out will include at the top, you can see it's kind of small writing, so I'm sorry about that, but it includes a purpose statement, an aim statement, an outcome measure, and a balancing measure at the top there, and then it moves into the table with your high impact changes, PVPs, process measures, and tools. So for this change package specifically, there are 3 separate high impact changes. We only see 2 on the screen, just couldn't fit the whole thing. But the 3 high impact changes for the panel processes change package are to be able to identify your patients on a panel, maintain your panel processes, and optimize the care management for the panel. And there's 9 potentially better practices to test out in the clinic. We can go to the next slide. This is the second example of a change package. This one is the screening and preventative care change package. This one has 5 high-impact changes. 2 of them you can see on the screen here are identify panel patients for care improvements and improve the patient experience. And that one you'll see repeated throughout quite a few of the change packages. And then what you can't see, but on the back side are the high-impact changes of optimizing screening processes, standardizing documentation, and coordinating care in the medical home. And I'll just show you one more on the next slide. Perfect. The opioid process improvement ones, and this one will probably look pretty familiar to those who've taken the opioid process training. And so this one, you'll see repeated high-impact changes like identifying your patients, improving the patient's experience, etc. So we can move on to the next slide.
Emily,
the idea,
yep. There is a question on the chat from Faith about the outcome and balancing measures, and I think it was put on earlier in the conversation, but maybe just wanted to highlight on all of these up at the top. There is the overarching outcome measure for the change package, or a sample one there that is outlined for each of them. And just one balancing measure is provided as a sample in this change package summary here. So I'll let you, if there's anything else you want to add about that, Emily.
Sure, yep, no, that's a good catch. So Faith, we do have, yes, those outcome and balancing measures at the top for the overall change package, and then we've identified a sample process measure for each of the potentially better practices. So for each of the potentially better practices, you could come up with an outcome and balancing measure, but just to keep things simple, we just have those outcome and balancing measures for the overall implementation. Hopefully that helps. Okay, so we can move on to the next one. Yeah. Okay, so the idea with aligning the change packages is so that practice facilitators can flex their same muscle. For example, you'll notice that many high-impact changes are repeated. So the identifying patients, improving the patient experience, standardizing documentation, coordinating care in the medical home, these you're going to see over and over and over again. And the idea is that once you're able to help clinics establish a new process in one clinical area of focus, it'll be easier to layer on the next area of focus. So for example, if you've established a process for reaching out and offering care planning to patients who are currently taking opioids, you can use that same process to reach out and offer care planning to other complex patients, such as those with multiple chronic diseases. So you'll be flexing that same muscle that you've already developed. So we can go to the next slide. So one of the ways that we can think about our work is through the frames of it sort of being simple, complicated, or complex. A simple problem often just needs a simple solution for which we likely have an established recipe. So if you follow the recipe precisely, your desired outcome can be achieved with a high degree of certainty. So a non-healthcare example of a simple problem would be baking a cake. So long as you have the right ingredients and the right quantities in the right order, your cake should rise and taste delicious. If we think about a simple healthcare example, we might think of something like drawing blood. So long as the patient is there, has veins that are visible, we have a phlebotomist who follows the recipe and has the right equipment, we can reliably draw blood with a high degree of success. Secondly, if we think about a complicated problem, these often require a more complicated solution for which we might have a number of different protocols. If you can follow the protocol, which might change based on circumstances, your desired outcome can be achieved with a high degree of certainty. And expertise often and experience often helps out here. So a non-healthcare example of a complicated problem would be launching a rocket. And if we think about a complicated healthcare example, we might think of something like fixing a broken leg. The degree of break in the leg or the location of the break might differ, but we have protocols that specialists can follow and often the break can reliably be fixed with a high degree of success. But the last category is the complex problems, and these often have different interrelating factors that make finding one solution impossible, and this is typically where our work lives. Complex problems, the context is constantly shifting, so there's no one right protocol that we can take to account for all variabilities. A non-healthcare example of this might be raising a child, but if we think about a complex healthcare example, we might think of providing timely, team-based, patient-centered primary care to a panel of over 1,000 patients. And much of our work operates within this space. And so this is where we see change packages coming in. Since we know we're often operating in a complex adaptive system, we need tools that support change or improvement. And change packages can take a complex problem and make it simple, or at least just make it complicated. The potentially better practices provide possible options to test, which will hopefully improve outcomes with a high degree of certainty. And this example here, I've got the little symbol in the corner, comes from the NHS School for Change Agents, and there's actually a change agent school starting, I think it is November 11th. If anybody on the call is interested, it's free to join. And so we can go to the next slide. We just have two quick poll everywhere questions before I turn it over to the field. So who has ever used a change package with a team? Yes, multiple times, yes, once, no, never, or you don't know. All right, we've got a pretty even split between the yeses and the no. Oh, that's great. Looks like the majority actually has used a change package, so glad to hear that. And we can go to our next slide. So for us at the AMA, we would be curious to better understand if you have, or even if you haven't used a change package, what are your concerns with using those one-pagers, should you have any? Buy-in, yeah, might be overwhelming. Yeah, buy-in's a big one. Someone likes them, that's good to hear. Navigation, yes, that's difficult, especially the first time. They aren't one-pagers, yes, thanks for the correction. They're often at least two-pagers. Lack of understanding from the clinic team, acceptance and thoughts of change, sources for the PBPs. Okay, that's interesting because that is something we could provide if that's a barrier. Hitting an uncommon barrier, what's next? Yeah, those are great. That's great feedback for our team. We'll take that into consideration and hopefully make them even more user-friendly. So that's it for me. Can hand it back to Matt.
Awesome, thank you, Emily. We'll just jump right into the next content. And so I'd like to introduce Tracy. She's a practice facilitator from Edmonton Oliver PCN. So go ahead, Tracy.
Thank you, Matt. So as Matt said, my name is Tracy. I'm a practice facilitator at Edmonton Oliver Primary Care Network. And today I'm going to be discussing a layering technique for multiple initiatives in the field. This information is loosely based on a case study of a family practice clinic that I have currently began working in. They are in the process of their patient medical home journey. Along this journey, they have decided to implement several initiatives successfully simultaneously. This clinic has 3 family practice physicians. All of the initiatives are separate and individual, and with our ultimate goal, establishing patient medical home. There are 2 full-time and 1 part-time family practice physicians at this clinic. They are currently quite understaffed, so efficiency and timing are paramount. I have found this to be quite typical in the majority of the clinics I have made contact with to date. I am learning in my role as a practice facilitator that the unique dynamics will be different in each of the clinics I encounter, but I do believe that the overall strategy can remain the same. As part of my job as a practice facilitator, I've been mandated to assess member physicians' clinics in their respective practices while determining the current state of readiness for the patient medical home journey. With the tools that my team and I have developed to actually assess their readiness, it will also help determine where they are actually at fundamentally for implementing the many initiatives they are interested in. The particular clinic was third on my list, and it's also the second clinic I have had to date to use the layering strategy. Establishing the end goal is instrumental in determining the strategic approach for each individual clinic, as there can be so many variables in each setting. For example, different time constraints, physician availability, team engagement, etc. The particular initiatives involved in this case study are ASAP, CII-CPAR, and opioid management. Of course, they are still, as always, on their patient medical home journey. I needed to get this clinic assessed and find out where they were at so I could meet them there, while having the implementation be as efficient and manageable as possible, and to keep the process rolling so as not to lose any of the amazing momentum that we had built. Upon first meeting, I came to understand that this clinic, while fully engaged, actually had very little knowledge of the current initiatives, the actual benefits of these initiatives, or the implementation procedures. But they did know that they wanted them as a part of their practice. These were things they had heard of, had some basic knowledge, but no particular information on each. They needed clarity and information first and foremost. Identifying the individual interests of each of the doctors while ultimately establishing patient medical home as our goal. I set up an initial kickoff meeting and was fortunate enough to have all 3 physicians and all of the clinic staff with me. I thought it prudent to provide all the information, resources, and details involved in the implementation process, as my goal was to lead this journey and empower this team into carrying the initiatives themselves once they were introduced, and all the while being available to provide ongoing support and encouragement. I believe having the full engagement of the entire clinic team has been instrumental in the successes that we've had to date. Each doctor had their own set of goals, and while each expressed interest in all, they all had specific reasons for wanting the different initiatives, again, with not quite enough information to get started. Having that, they also believe that working the team together to produce these results is also ultimately the best case scenario when implementing multiple initiatives. Determining the next steps and process depends on the steps needed to implement each initiative and identifying the similar steps in order to overlap effectively. To slide 2, please. For example, a clinic would like to simultaneously sign up for CII-CPAR, begin ASAP screening maneuvers, and improve their opioid patient management. The clinic is also wanting to begin their patient medical home. And slide 3. Regardless of the initiative, all projects start with a work plan outlining the activities, tasks, and steps needed to complete the project. Slide 4. When layering initiatives, first identify the individual steps required for implementing each individual initiative, and then look for areas of overlap. And slide 5. Consider how each step could impact other initiatives. For example, where can steps be combined to reduce time in meetings and reduce change fatigue for clinic teams and doctors as well? And are there any steps which must directly precede or follow another? For example, EMR configuration sessions for clinic teams for 2 initiatives can be done simultaneously, reducing the need to monopolize more of the short-staffed clinic's team than absolutely necessary, as well as providing the opportunity for the team to learn the new initiatives and workflows together. determining whether or not there are steps that will require specific timelines in the process. For example, developing the templates for the screening, yet not activating them in the EMR until the clinic staff and physicians have been shown how to apply them can obviously avoid confusion. So slide 6. Individual work plans may look something like this. These are the steps needed to implement ASAP maneuvers. And slide 7. These individual work plans may also look something like this. These are the steps for CII-CPAR. And next slide, please. These are also the steps, individualized, of course, that needed to implement opioid management. Slide 9, please. Here we can highlight each of the steps. We can see the like steps and activities in each maneuver, which could potentially be combined. Next slide, please. Prioritizing the overall work plan to account for milestone activities, which could be done collaboratively in one session rather than in many. Next slide. Rather than completing each initiative start to finish before beginning the next, consider which steps are like between initiatives and how they can complement each other for patient-centered care outcomes. Consider the roles of the team as well. If the same person will be completing similar tasks for patient management, consider how to make their overall workflow most efficient. Next slide. How to decide what to combine. Looking for ways to get the most out of each clinic visit or team meeting. Considering, do the outcomes of this step overlap? Who will be performing the actions of the final processes? How will this combination affect current clinic operations and workflow? Team teaching and EMR configuration should ideally be done simultaneously for more than one initiative to reduce clinic fatigue and also to maintain workflow continuity. Next slide, please. I was asked to identify the keys to success, or why I thought that the work that we've done in this clinic has been successful to date. Some of the things that I have chosen or believe are the keys to the success so far is that all of the physicians in the clinic and the team as well have been fully engaged from start to finish. I do honestly believe that that's been the biggest key to success. The tools and resources that are made available through the TOP and collaborative websites, utilizing as many tools and resources as possible, because I also believe that knowledge is power for both myself and for the clinic teams. Supports at the AMA for guidance with the PIA process, which can be a little bit daunting, has definitely contributed to our success. It actually got us through the first roadblock. The amazing collaboration, support, and encouragement from my colleagues and managers at the Edmonton Oliver PCN, which of course have been my sounding boards and have definitely helped along the way. I don't believe that anybody can be in this process can be successful individually. It does definitely take a team to make these kind of changes and to have the implementation process go as smoothly as possible. Some of the lessons that I've learned along the way. Next slide, please. There are always supports and guidance available, whether it's the coworkers, the AMA. There's just so many supports available in this role that just makes it fantastic to be a practice facilitator. Definitely reach out when it's needed. I mean, with the PIA process, we had, I reached out, there was some information there, another practice facilitator kind of having the same, a few of the same issues I was. Everybody kind of gathered around and said, okay, what's the issue, and let's help with this. That essentially, so definitely reach out to anybody, coworkers. There's lots of support out there if you're looking. Privacy impact assessment requirements for CII-CPAR can be a bit intimidating, but there's definitely information. I have had terrific support from the AMA with this project along the way. Another thing I've learned is very few physicians have that I've encountered have actually know where their PIA is, who holds it, where it's at, how to get information. So arming yourself with that information first and foremost. And if any of the work you're doing in the clinic is going to involve the PIA at all, maybe just start with that first. It did seem to be a bit of a roadblock along the way, but again, with the support that I received, we've got that all figured out and we're full speed ahead. I've also learned that keeping the end in mind has been one of the biggest keys to success. Because if you know where you're going, you don't know how to get where you're going if you can't keep that end in mind always. I believe that's another thing that has made this successful. The work if you could advance to the next slide, please. Where are they now? I'm actually still working with this clinic. We do have a little bit of work left to go. We are almost finished, actually. We've developed their screening maneuvers for ASAP. We have EMR configuration and standardization complete. We do have a teaching session actually coming up this week, which again, with this fantastic crew that I've been given to work with, the doctors, the entire clinic team will be there. I know that's not always possible, so I'm extra grateful for that. We have submitted their confirmation of participation, and the next and last teaching session, like I said, would be this week. And then we will have one following the going live date for CIIC part. We will be finishing off with the ASAP maneuvers and opioid management workflows, having a teaching session there on Friday. I'm actually really looking forward to that. The doctors have all called to check in, make sure that we're still full speed ahead, which we are, and maybe at some point I will have a chance to update. So that's all I have for today. If there's any questions, we could head to the next slide, and if not, thank you so much.
Thanks, Tracy. I do see one question really quick. What is your secret sauce for your engaged physicians and clinic teams?
Secret sauce. I'm not sure about secret sauce, but I have found one of the biggest concerns that they all had, of course, and this is a fairly small clinic as well, just with the three physicians, they are very busy. What I would have to say would be just they were all so terrified of the change. I tried to do as best I could to keep it fun, to just keep reminding them of the benefits and the features, that these would be long-lasting results. It wouldn't just be something we were just going to quickly throw in and, in another 6 months there's going to be something else or whatever. Giving them the information, enough of the information, and also, quite frankly, just letting them know that there wasn't a lot of physician involvement here. I just let them know that I would be facilitating these changes with their clinic team. They just would need to make a few of the decisions along the way as far as, which maneuvers to monopolize, making the decision to utilize CIIC part, to do the mapping. But again, this is the second clinic that I've had this layering strategy in, and because this team was so engaged, I just found to keep it upbeat and friendly, and I love the work, and I honestly believe that got through to them. So if I'm loving the work, they've got to love it too. So I don't know, I guess that would be what I could answer for secret sauce. Hope that answered your question.
Yeah, that's awesome. Thank you very much. If anybody else has any questions, feel free to type it in the chat, and we'll get Tracy to answer them later, and we can put it up on the discussion board. So just moving right along, continuing with the layering initiatives in the field, we have another member of a PCN to discuss. This is Lacey. She's from McLeod River, and I can pass it on to her.
Hi, thanks very much. It's very nice to be invited to speak here and talk with all of you such smart people today. I'm Lacey, and I'm from the McLeod River Primary Care Network, and I kind of have a unique role as far as starting to implement these types of foundational work in the clinic, because I'm both the improvement facilitator and also part of the clinic improvement team, which is part of the process for integrating these changes into our current clinic processes. So you kind of get a good look at not only what these changes are going to kind of look like in a theoretical view, but also in an application view, and what kind of barriers came up and what kind of roadblocks there are, and as you were starting to put in these initiatives. I know when we look at the bigger picture and all of these toolkits and all of these initiatives that are coming out, it can be quite daunting and it can be really overwhelming. But where do we start? I know with many of the clinics, we started same place that we all did. We began with just paneling work. We have some clinics out in McLeod River that don't even have an EMR yet. They're still on paper charts. So obviously it's going to look a little bit different in each clinic, and that's okay. For lots of clinics, it's going to be looking at some of the strategies in the toolkits or the suggestions when you start the paneling work and finding what's going to fit for you. I know for us specifically, when we started doing the paneling work, there was a lot of fear-based in the change in processes, or physicians worrying about who's going to be looking at this data and who is going to, is somebody going to be holding me accountable for these patients now that they're paneled to me, and what does this mean for my practice? But it was a good way to start having those conversations around how to change and better our practice, and using it as an opportunity to knowledge transfer, that the better identification of a panel allows us to know how to better address care to them, and knowing your panel and knowing who they are allows you to provide more access and just better improved care to them. So I really found that when we started doing paneling work in the clinic, it really just opened the gate for a whole bunch of other foundational elements that really were essential to start building any of those more complex programs or projects on. So once we started paneling, we started screening using the ASAP maneuvers, and I know there's so many maneuvers that are projects that have come down the pipe, whether it be AIM or ASAP or PACT or RIFS or whatever it is. There's always something, and I know within teams it can be quite fatiguing, and you're like, okay, well, this is just another thing that I have to end up doing, and that I have to put on my clinic improvement team or all of the clinic team. But I liked what Tracy said, that these are long-standing changes. These are not just things that are part of our distinct chapter. This is part of our book as a clinic, and writing the culture of how we are wanting to practice and provide patient care. So when we started our paneling and screening and then moved on to our verification rates, it was kind of just an organic thing that was created, that we had a QI team, and it came about in a way that we needed to exchange information about our paneling, screening, verification, whether it be roadblocks, successes, just process adaptation. So we would end up meeting just kind of in the hallway in the morning when we would have coffee, and then pretty soon that turned into a huddle with the whole team in the morning, and we would still have coffee, and then, it turned out that we had more in-depth things that we needed to discuss, and we're like, okay, well, where do we find this time? We can't we can't any longer just squeeze it in the morning before we start our daily duties. We need to start, carving out and protecting some time for it. And that was how our QI team meetings and the frequency of them got established. Yes, it was a byproduct, and yes, it was kind of a natural process to things that. But it's essential. If you plan on taking on these larger projects that are more complex and more in depth, you really need your team of ideas who can really bring the information, put it into implementation, and then support the process as it's rolled out. So that was an interesting thing that came from just this foundational work. The other thing that was bred out of that is engagement. Once you started doing these projects, and we were meeting as a group and supporting each other as a group, all the team members are engaged. They're like, oh, okay, my ideas are being listened to. I'm having input on meaningful, sustainable changes in the clinic, and my workflow is more meaningful to me, which that really helped with our engagement part. And then as we knowledge transferred, sending more of our team members to more events where they could meet up with, other MOAs that are doing interesting in their clinics, or how is somebody else doing it, some of the same maneuvers, and what can you take back, and what can we apply to our practice. And then another interesting byproduct was all of a sudden your EMR was suddenly such a critical part of your clinic improvement team. When you've implemented this foundation, if you paid attention to your paneling and you're doing your screening and your verification is on the rise, all of a sudden you can get data from your EMR that is realistic and qualifiable, and it can just provide so much more data in the drop of a hat, and then you're able to teach your team members how to extract that data and apply it. So that was kind of what we did foundationally to start taking on and layering all of these projects that are coming out. If you want to go to the next slide. So like I said, all the projects that have come down, I mean, I didn't, there's a few more that were presented through TOP years ago, and it didn't, we weren't really at a place clinically to start moving forward. So it did just kind of seem like, for example, when we did AIM the first time, we were, collecting access and TNA, but we weren't using it for anything. It wasn't really applicable to our practice because we were doing the project and we were moving through all the test boxes and projects, and we were ticking the boxes, but it wasn't meaningful to us because we weren't really using it. We weren't at a point where we were projecting what our TNA was and how do we impact it, how do we carve out this time. So it wasn't until we really wanted to start doing ASAP that we were able to really find out what AIM was and how we could apply it to our practice. So then this included, looking at our physician schedules. What is their TNA? How do we get it to a reasonable level? Why are patients going to, maybe emergency department or seeing other physicians when they could be seeing their doctor? Oh, it's because they have to wait 17 days to see their doctor. Well, no wonder. So how do we impact that? How do we project it? How do we be proactive instead of reactive? Instead of waiting until that TNA is 5 or 10 or 15, how do we impact it now? How do we carve out the time to get that backlog down in order to be seeing those patients for meaningful visits like ASAP or complex care planning? So with our foundational work in place, especially paneling, we're able to carve out meaningful appointments with those physicians so that the physician can say, that is my patient. Okay, I see that they're due for screening. I'll carve out time for my patient. Maybe this isn't, a same-day appointment where, it's just a quick in and out, but this is my patient. This is important. Yes, I'll carve out time for this. And then we were able to get down to the backlog. And not only with that, you're able to establish practices to begin your ASAP screening maneuvers. With the development of all these projects within the clinic, we quickly came to realize that our structure and how we had our MOAs working needed to be changed. Initially, we had ushers and just receptionists, so the physicians didn't have an MOA. They just shared my role here as the CDM, and I would try to go in and update screening and problems lists and surgical histories for all of the physicians, just trying to pick the most complex patients and making sure that those charts were up to date. But really, once you start this work, it was just too much. It's too much work for one person to be shared between 6 physicians. So that was when the physicians agreed that each one would have an MOA. And that has really been revolutionary in providing qualitative data to justify these MOAs, working with each of their physicians. This foundational work just set it up for success. Now, the MOAs manage those physician schedules. They do all of the screening. They book complex care planning. And now they're set up to do those outreach for PACT patients, for the opioid risk project, for the RIFs work. Those who aren't maybe familiar with RIFs is the reducing the impact of financial strain, and it's a provincial initiative that we're doing here as well. But they all build together. As far as the PACT project, it's kind of an extensive workhorse. It's ongoing, and it's seeing those complex patients that are maybe not necessarily that they qualify for complex care planning like the 0304J, but they're patients that are rising risk, that the physician is seeing them on an ongoing basis and they're seeing them repetitively for the same thing, but you're never really getting to the bottom of what's going on with them. So these are the patients that need that support at that clinical level by the multidisciplinary team, which really makes an impact having that MOA work specifically with that physician and having your multidisciplinary team in-house so you can really leverage those initiatives. So these were...
Lacey,
yes?
not to give you too much of a time crunch, but we do only have about 5-6 minutes left.
Okay, great. You can go to the next slide. So looking at those tools that or those projects that that we're looking at implementing in our clinical process, they all came with toolkits. Well, what is a toolkit? We've never used them before. They look quite extensive. There's a lot of work tied to them. I kind of like the analogy of that a toolkit is like a specialized woodworking tool. I can look at it. I know that it's kind of used for woodworking, but I may not know exactly what it does. And it's not until I see my friend use it or I watch a YouTube video that I can truly understand what it can do, and then I can look at what its function is and see how it can be applied to my process or my project. And toolkits are much like that. I can look at the toolkit, but until I start clicking through it and seeing how it's used, I can't really apply it to my project till I understand it. The toolkits with RIFs and PACT, they were quite extensive, but many of the things, like Tracy had said, were layered in them, and so we could kind of flex that same muscle. Okay, my paneling's done, my screening's done, my verification's great. Okay, I can jumpstart and start implementing these toolkits to reach out to these complex patients. Next slide. As always, there's always challenges. I think the biggest ones that we ran into was keeping the quality improvement time protected. This is where we met with our quality improvement team to go through the toolboxes and work through the changes that need to be made. That's a really important thing that just stemmed engagement. That time was protected. It was expected. We had agendas. We attended, and our ideas were all presented and captured. That was really the biggest thing. And then third was finding a place to capture all of our work in our EMR to optimize it to its fullest. Lots of times the toolkits come and they're not a specific recipe. They're more like a menu, right? And they're not always all mapped out exactly where you should document and capture these things. Next slide. Yeah. So our next steps are really focusing on changing our culture in our clinic. Like the analogy of it's not fast food anymore. We're not just focused on access. Do you have speedy access to a physician? That's not really our goal anymore. Our goal is to provide quality care with your physician to create that medical home. It's not acceptable anymore for the quick access and the fast food. Yes, you're getting food, but it's creating more problems than it's solving. So that's really what our hopes are, is to continue building on our patient-centered medical home and really attaching our patients in a meaningful way to their physicians. Next slide.
That was great. Thank you, Lacey.
Thank you.
If there's any questions, we will address them on the discussion board. And just for the interest of time, we'll jump to the next slide and go through the next little bit. I really liked your reference to like fast food care and like that kind of whole thing. That was really cool. Just a reminder for everybody, we do put the resources on the Collaborate site. So if you know someone who missed or that would be interested, you can find them all on there. And we'll go to the next slide. A reminder to anybody who would be interested in joining the Collaborate, send an email to info@pcnpmo.ca and try your best to include all the check boxes that are listed on here, your name, email, where you work. You will later get an email back with your login information. And next slide. Just to kind of slide to summarize all of the Practice Facilitator Network supports. There's kind of this trifecta of webinars, Collaborate, and email. Just for access to all sorts of information that can be provided. There's a section called Collaborate on the website where all of our stuff is listed. You can email the IF Network anytime to get answers from the admin or community, and webinars are obviously every month, first Monday of each month, excluding holidays, from 2 o'clock to 3 o'clock p.m. So one last thing, right on the dot before I let anybody go, if on the next slide, if you could jump back on your phone and just give your input for what you thought of the webinar today. I know it's tough to see, but it looks like a lot of smiley faces, so that's great to hear. And with that said, it's 3 o'clock. Thank you everybody for joining. If you have any questions, feel free to send an email or consult this webinar that'll be posted on the Collaborate site. Thank you to all of our speakers. I hope everybody enjoyed it.
Thank you.